All right, welcome back. Today we are diving into a true medical emergency, heparin-induced thrombocytopenia, or what you'll hear called HIT. For you as a medical trainee, this is one of those high-stakes diagnoses where acting fast and knowing your stuff can literally save a life. So let's jump right in. So let's just start with why this is such a big deal. 53%. Just let that number sink in for a second. That is the 30-day risk of a blood clot in patients with untreated HIT who don't even have a clot when they first present. It's a staggering number, and it tells you that when you suspect HIT, every single minute counts. So to get you ready to manage this, we're going to walk through 6 key steps. We'll start with why HIT is such an emergency, then cover how to suspect it, what your first 3 actions must be, how to choose the right anticoagulant, what to do when you confirm the diagnosis, and finally, the really crucial lifelong implications for your patient. All right, Section 1, the HIT emergency. First up, what exactly is HIT, and why is it considered one of the most dangerous drug reactions in all of medicine? Okay, so at its most basic level, HIT is an immune reaction gone haywire. When some patients get heparin, their body mistakenly creates these autoantibodies. These antibodies target a complex made of heparin and something called platelet factor 4, or PF4. And here's the crazy part. These antibodies don't just get rid of platelets. They actually hit the accelerator, activating them on a massive scale and kicking off a dangerous widespread clotting cascade. And that right there is the terrifying paradox of HIT. You're giving a drug to prevent clots, and instead it kicks off this insane chain reaction that causes catastrophic clotting. We're talking both venous and arterial clots here. And if you don't jump on it immediately, the mortality rate can be a jaw-dropping 20%. Okay, so that brings us to maybe the most critical first step when you're on the wards. How do you even start to suspect HIT in the first place? Well, it all begins with a really important clinical tool. So picture this. Your patient's on heparin, and you see their platelet count start to drop. Is it HIT? Or is it one of, I don't know, a dozen other things it could be? You can't just guess. You need a way to quantify your suspicion, and you need to do it fast. Well, the tool you're going to reach for is the 4T score. This helps you figure out the pretest probability. It's really straightforward. It looks at 4 things. First, T, thrombocytopenia. A big drop, more than 50%, gets you the most points. Second is timing. The classic window is 5 to 10 days after starting heparin. Third is thrombosis. Is there a new clot? And finally, the 4th T is for alternative causes. Are there any other good explanations for the low platelets? And here is the absolute bottom line. Once you add up the points, if that score comes back as intermediate or high, you have to treat it as a presumptive diagnosis of HIT. You act immediately. You just don't have time to sit around and wait for the lab test to confirm it. Okay, Section 3. Let's talk about your first 3 moves. Once your suspicion is high, your response has to be a clear 3-step protocol. Look, I'm going to say this again, and I really want this to stick, because if you take one thing away from this whole explainer, it's this. You treat based on strong clinical suspicion. Waiting for lab confirmation is a dangerous and potentially fatal delay. All right, here's your playbook. Step 1, stop every single source of heparin. I mean, everything. IV drips, sub-Q shots, the heparin flushes and IV lines, even heparin-bonded catheters. Step 2, if your patient's on warfarin, you stop it and you give vitamin K to reverse it. Why? Because warfarin's first move is to knock out these anticoagulant proteins, which can actually make the clotting and HIT worse and lead to awful things like skin necrosis. And finally, step 3, you have to start a full therapeutic dose of a non-heparin anticoagulant. All right, so you know you need to start a non-heparin anticoagulant. Easy enough, right? But which one? The choice isn't random. It has to be tailored to the specific patient that's right there in front of you. This is the very next question that's going to pop into your head, or the one your attending is going to ask you. You've got options: argatroban, bivalirudin, fondaparinux, even the DOACs. So how on earth do you decide? Your choice is going to come down to 4 key questions you need to ask. First, how urgent is it? An active, life-threatening clot needs a fast-acting IV agent. Second, what's the bleeding risk? If it's high, you want something with a short half-life that you can turn off quickly. Third, what's their organ function like? Kidney or liver disease totally changes which drugs are safe. And finally, what's the route? Does the patient need an IV, or can they take something by mouth? Now this is a fantastic cheat sheet. Let's say your patient has bad kidneys. Argatroban is a go-to because it's cleared by the liver. On the flip side, if they have liver disease, you'd probably lean towards something like bibilirudin or fondaparinux. For a patient with a high risk of bleeding, those short-acting IV drugs like argatroban are a huge plus. And of course, for a stable patient who doesn't need an IV, you can think about subcutaneous fondaparinux or one of the oral DOACs.
Okay, so you've made your first moves, the patient is stabilized. Now, those lab results you sent off are starting to trickle in. Let's talk about how to use that new information to confirm the diagnosis and plan out the treatment duration.
Remember, you started treatment based on your clinical suspicion, right? But the definitive diagnosis, the final proof, comes from the HIT antibody tests. An ELISA test can find the antibodies, and a functional test, like the serotonin release assay or SRA, actually confirms that those antibodies are activating platelets. These results are absolutely crucial for your long-term game plan. So how long do you keep this up? It all comes down to one simple question. Did the patient actually develop a clot? If HIT is confirmed but they never got a thrombosis, you're looking at about 4 weeks of anticoagulation, minimum. But if they did have a clot, then you're treating for at least 3 months, similar to any other standard DVT or PE.
So, what about switching to an oral medication like warfarin for the long haul? When can you do that? Well, you absolutely must wait until the platelet count has recovered. And the magic number here, the one you cannot forget, is 150,000. If you try to transition before that, you risk that dangerous warfarin-induced skin necrosis we talked about.
All right, we're at our last section. And honestly, this might be the one that has the biggest, longest-lasting impact on your patient's entire life. This quote from the guidelines really just says it all. A diagnosis of HIT is a life sentence of heparin avoidance. This is not a for a little while thing. This is forever. If they get re-exposed, it can trigger another, even faster and more severe HIT reaction. This has to be crystal clear to the patient, to their family, and it needs to be documented everywhere as a severe allergy. And look, this is way more than just telling them to avoid heparin drips. You really have to become a heparin detective. Low molecular weight heparins like enoxaparin, totally off limits. Those tiny amounts in heparin flushes for IV lines, nope. Heparin-coated catheters, can't use them. It can even hide in some reversal agents like PCCs or in TPN bags. You have to be incredibly vigilant. So you did it. You navigated the crisis. Your patient is safe. But your job isn't quite done. So I'm going to leave you with this question to think about. How are you going to make sure this critical diagnosis follows them for the rest of their life? Because putting it in the chart, getting them an allergy bracelet, and doing thorough patient education, those are the final essential steps to truly managing HIT.